It's my pleasure to introduce Dr. Simon Lowe from Cedars-Sinai. Simon is going to be talking to us about ERCP biliary stenting and which stent for which indications. And then after this, we're going to go to the live, live presentations. Then we're going to get some videos at the end. So Simon, again, thank you for joining, and also one of our co-moderators. Thank you.
Thank you, Tom. Thank you, everybody, for the invitation. Just want to say that it was really not much to talk about. It's only metal or plastic stent, so, and we can use either one. But the reality is that actually it's more complicated than that. Well, I just want to start a little bit with the historical perspective. Those of us who've been around for a while like to talk history. Those young guys don't want to hear that. So anyway, Dr. Nipso-Hendra started the first plastic stent, and that evolved into the whole field that we're going to talk about now. On the left side was his original study published in 1979 using a modified pigtail type stents from other field and 7 French and placed in the bile duct. And most people don't know who it is now, but it really is a master of the field. This is another mentor of mine, Dr. Kees Huybrechtse, who's from Amsterdam. And he started placing the first real plastic stent. It's called Amsterdam stent in 1989. And on the right side is a first wall stent, which is the metal stent that started the whole biliary metal stent field. He and Neuhaus published simultaneously in the same journal of 2 different experiences of using metal stents. Those are uncovered stent at that time. Probably the most common biliary stenting that we do nowadays are for distal bile duct strictures, and mostly formed by pancreatic cancers. When you do the ERCP, in the index ERCP, most of the time we do plastic stent placement, mostly because we are accustomed to not having a diagnosis at that time. So we need to do something that we can always retrieve at that point. And partially is because either the patient have a short duration of survival, or that the patient might go on to surgery for resection, so we place plastic stent cheaper. But more recently, we have been moving into the metal stents. One of the keys is propelled by the fact that we're now able to do endoscopic ultrasound almost simultaneously, so you get to know what is causing the problem. And also, US is usually pretty good in obtaining tissue for biopsy these days. So we don't have all this ambiguity of diagnosis. And nowadays also survival seems to be a little bit longer. I would say most patients with pancreatic cancer, the median survival is at least 6 months, if not longer. Plastic stent, if you place it, that means that the patient will automatically need to be exchanged. Just talk about what is, if you know the diagnosis, what's the best way of stenting plastic or metal of the distal bile duct stent. It's really, by now, we have volumes of studies, and there are different meta-analysis using the different combination of studies, and all of them show expandable metal stent is the best comparing to plastic stent, and certainly the quality of life for the patient is much better. So there's no denial that if you know the diagnosis of distal bile duct stricture from pancreatic cancer, use metal stent for sure. And of course, if you're still not sure what it is, you can always put a cover metal stent, which allow you the possibility of later on removing it. Why is it so important? Look at this data. This is a really nice study from Tim Gardner several years ago. They have diagnosis of pancreatic cancer of patient obstructing distal bile duct. And in this modern day era, we do a lot of this like neoadjuvant therapy for patients before pancreatic cancer resections. And even for our pancreatic surgery, even if they look like a upfront resectable cancer, they don't do that anymore. Major center, Mayo Clinic, and MD Anderson certainly do that as well, using neoadjuvant first, because the data seem to favor better outcome. So anyway, what they did is that they have a small group of patients, 80, and they randomized into 3 groups. And they use on the left side is folded cover metal stent, and the middle is uncovered metal stent, and then the right side was only plastic stents up front for placement of these patients, treating these patients with strictures. And they look at the endpoint was whether the first occlusion of the bile duct stent or the surgical resection of the patient died within this time. And so, no surprise, is the folded cover metal stent has the longest time to the first index whether the patient died or stent occlusion. The uncovered metal stent, surprisingly, actually doesn't last that long. It's only like 2.5 months. Very similar to plastic stent in the patency for that, or till death. What's interesting is that the total cost, no matter how they randomize, it's the same. But interestingly, the plastic stent patient have very little complication in index situation. What happened is that the metal stent patients have more adverse events. I believe they didn't talk about that, but I believe there's mostly pancreatitis, and they might not have cut the sphincters, and that might have been the reason for this adverse event. But anyway, the bottom line is that the cost is about the same whenever what you do, plastic, fully cover or uncover. But what's important is this. If you use plastic stent, you delay the patient a lot for the initiation of adjuvant therapy, which ultimately that's what you want the patient to do, is to get going with the therapy so that they can hopefully have a better outcome. So if you look at this data, I think that is clear that if you upfront fully covered metal stent for the patient who going to have ability to undergo surgical resection or neoadjuvant therapy, should be just metal stent for these patients. Now, so for the hilar strictures, there are a lot of meta-analysis, but there's not really a whole lot of data to show what to do. There are basically 3 randomized controlled trials and then a bunch of retrospective reviews. And if you look at this, this is like a long plastic stent, actually much better survival than all these other metal stents. And some are neutral. So basically, if you look at the patient survival, plastic or metal for the hilar stents, no difference. But if you look at the patency of the stent, it really favored the metal stent, right? You look at all of them favoring the metal stent on this side. The problem is most of these studies did not do a programmed exchange stents. They basically went into the stent clock and then exchange. So of course, the patency of plastic is shorter upfront compared to metal stents. But anyway, if you look at the society recommendation, is very interesting. Is whether you're American or European. It's a big difference. So the American Society actually last year recommended that if you have hilar stents, you can either place metal stent, or which is usually uncovered metal stent, or plastic stent. It doesn't really matter because there's no strong data favoring one or the other. But if you do stent these patient hilar strictures, there's strong data showing that you should stent bilateral rather than unilateral obstructions with stents. But the Europeans, very interesting, they're very, very strongly argue against using plastic stent. They basically recommend using metal stent based on mostly the 2 or 3 randomized controlled trials, which in my opinion, they're off fault, have flaws in them. It's because all the randomizations using 7 French stents, plastic. Who used 7 French plastic stent as a treatment of choice? And also they did not program exchange the stent. They basically wait until the stent occlude, then you exchange it. And we all know that if once the stent is clogged, you're going to get complication with cholangitis and other things, and it become much more acute, much harder to treat. So these are really bad design studies, in my opinion. So I personally think that we should go by the Americans' recommendation. So there's one of the interesting one, just for interest to show you. There's one of our patients who went to Korea for treatment after having a hilar stricture. Korea is very famous for bilateral metal stents, so they confirmed the stricture, put in double stents. Ignore this one. This is very interesting. This is actually these opacified ducts. Actually, it's not ducts. They are actually the portal vein occlusion, basically by occluding the one side of the liver, so that you allowed hypertrophy of the other side, then would ultimately trying to resect the side that's occluded of the portal vein. There's the major centers like ours that do them. But anyway, it turns out the patient was not resectable. So they ended up putting a so-called Y stent, which is very popularly done in Korea. But the patient then came back to us. Now we have to keep every 3 months do plastic stent to go through the metal stents in this patient. So that's the problem when you do metal stent in the hilar strictures. And I think they actually quite likely promote the premature death because of cholangitis and blockages. But that is not quite answered yet, in my opinion. We need more data in better randomized controlled studies. And now, so when you have obstruction from cancer or from bile duct obstruction, so what of whatever variety, what if you fail to get into the bile duct? We all face that sometimes in doing ERCP. Well, one thing we know that you can try again, or refer to an expert in your hometown or another town, or ask the radiologist to do percutaneous transhepatic drainage, right? That's clear. But nowadays, if you are skilled and you have a genuine blockage that's not possible to treat, then you can do transluminal type drainage approaches. There's one of the studies that you can actually put one of these lamps or luminal pulsing metal stents across the duodenum into the bile duct to drain the bile duct directly. And so it's every day you're seeing new trials and new studies that they're using this lamps treatment. And there is commercially available now. You can buy them. They're usually smaller. If you look at that, they actually in this study, they actually use all kinds of sizes, but usually right now the commercial one is like a smaller stent comparing to those that we use to drain the pancreatic pseudocysts or necrosis. How about in switching subject? Another way of applying stents is now in gallbladder in patients who have acute cholecystitis. I just placed 2 plastic stents this week in the gallbladder patients. For this type of unfit patients who are usually cirrhotics and acute cholecystitis surgeons don't want to operate. And it's not really a good solution to do a transhepatic drain because they also have ascites and maybe coagulopathy. They don't want to puncture the liver to go into the gallbladder to drain. So this is a way to avoid having that. You do a long plastic stent, usually the 15-centimeter stent. Most people use double pigtail. I don't, because if you need to exchange it, you can exchange because double pigtail is really, you cannot exchange. So I would usually cut off the lower end of the double pigtail to make it straight so that I can put a guide wire through for exchange. And it's basically the success rate, as you can imagine, even in the big centers like this, these are usually data from the big centers. Getting to a gallbladder is not always easy. So it's about 15% failure of getting in. But once you can put the stent in, the success rate of unclogging the cystic duct, meaning that you're treating successfully the gallbladder cholecystitis is 95%. So it's really good if you can get in. Basically, the other way is to nowadays to use this LAMPS approach. Somehow I send my video over to embed it because there's too large a file, but there's not a video, it's not running, so I can't show you. But anyways, it's quite easy to do if you're technically capable. You can just go transluminally from the duodenum or from the stomach. This is a gallbladder that's sick with stones and thickened wall and all this. And basically, one of these hot lamps. You can puncture directly and then release the stent between this and the duodenum, which is the preferred location. And that's really drained this gallbladder quite well. And it's been comparative studies looking at these, how do we do, like, are we just trying to do something because we could, or are we doing something because we're better than the percutaneous transhepatic drainage, which has been the classic way of treating these patients. Now, obviously, this technology is available in virtually all hospitals. This technology with the duodenal or gastric gallbladder drainage is mostly available only in the major centers. I think that this type of technology may become more available as it gets better in more hospitals. But anyway, if you look at the comparison, large group of patients, the endoscopic ultrasound guided gallbladder drainage is superior to the percutaneous in every way, including fewer adverse events, shorter hospital stay, fewer reinterventions, and fewer readmissions that's unplanned. So really, I think that this is going to be replaced. And in fact, as I'm driving into this hotel, my radiologist called me and saying, how am I going to remove this percutaneous drain that you just put in the gallbladder drain yesterday? And he said, you know, what is this gallbladder stent that you guys are placing? And where are you putting this from? I said, you know what, we've been placing a lot of them, probably 100 of them in this hospital. I was surprised that he just found out now that we've been doing them. So anyway, how about switching focus to benign strictures? How good are we collectively in long-term success in stenting and improving stricture resolution after removal of stents? You look at all the data, whatever that the benign stricture in the bile duct, that is about 3/4 of patients get better if you do long-term plastic or metal stents for a while and then remove them. And one of the most common applications, obviously post-transplantation, duct-to-duct anastomotic strictures. And we know that the conventional way of treating based on the Rome criteria, Guido Castamagna placed these plastic tempering stents as large, as many as possible to jam the bile duct. That's his style over 1 year. And then after removal, there's about a 90% to 95% success rate of over 10 years after the stent have been removed. So that's the mainstay of and evidence to treat benign strictures. And so it's been applied to the post-transplantation as well. But more in the last 10 years, it's been fully covered metal stent used by others for 6 months and see what happens. Basically, the bottom line is that with all these randomized controlled trials, it looks like the data shows that the metal and plastics are about the same. And of course, there's less number of ERCP that's needed for the metal stents. So I think that this may sway us to gradually move over from plastic to metal stents. Although I have seen a few cases of failure, but metal stents certainly easier on the patient. And how about chronic pancreatitis? How good are we in stenting? There's been a couple of randomized controlled trials. This one in 2015, showing that if you use multiple plastic stents over 1 year or using 6 months of metal stents, it's actually about the same. And this is a more recent study from India and from Dr. Reddy's group in Hyderabad, and shows that it basically, if you plastic stent is the bottom line, if you use many large number of plastic stent versus metal stent for 6 months, you're going to have about a 75% success rate after you remove the stent for long-term follow-up. But obviously, again, the more number of ERCP needed with the plastic stent. So you can certainly try, but you have to make sure that about 25% of patients, even if you do the stenting, they still come back with strictures and may still need to have surgery later on. Another way of treating using stent applications in bioleak situation. It's very interesting. There's one small study from Virginia Mason. They used either stentotomy alone, or stent alone, or stentotomy and stent. Basically, the data shows from their experience that is significantly about maybe 5 to 10% better in using either stent alone or stent plus stentotomy comparing to those who use stentotomy. Yes, it can be done, but it's about 10% failure in these patients. The only problem is sometimes that you don't know what kind of stent to use because the straight stents tend to migrate and you can have failure because of that, because these stents are designed to stent strictures. So if you don't have a stricture, the flap doesn't hold the stent well, then frequently migrate downward and causing obstruction and failure. Just a lot of other miscellaneous applications, including cholangitis. Don't forget you can use nasal biliary drain, which is a form of a stent. It's kind of a lost art, but it's really very, very effective in especially treating acute cholangitis situation. You can use a stent for stone disease, liver abscess, especially from cancer obstructions. You can drain it endoscopically. There's a very difficult problem with this IPMN that is actually eroded into the gallbladder, into the bile duct. These patients, no matter what stent you put in, it doesn't work. We have even put in esophageal type stent, large caliber, you still get obstructed from this. And of course, do you stent or not stent with PSC? Most of the time, we don't do PSC stenting. If you do stent it, probably only for a couple of weeks. Otherwise, they will start getting cholangitis. And hemophilia is also another problem because these are, depending on the etiology, hemophilia can be treated with stenting, but also stenting can actually make hemophilia worse because it may clog up the stents, especially plastic. Just 30 seconds to remind people, uncovered metal stents should not be used if the diagnosis is benign, or if you don't have the diagnosis of what causes the stricture. You can always put cover metal stent these days. There's no excuse for that. Transluminal stenting, all this fancy stenting, poking through the bile duct and stuff, is not for a substitution for poor techniques. So I know that there are a lot of young guys who like to put transhepatic. I probably the last 5 years, I did one transhepatic approach, rendezvous. And so it's really, you don't need to do that if you don't have to. The other thing is that the metal stent is very easy to place. So we are seeing more and more patients with metal stent placed in the wrong thing. This is a false track because metal stent doesn't need any force. So you just basically put it in the track and you think that you're in the bile duct, they put a metal stent, basically the patient got worse after the procedure. Now, the good thing is that if you discover it early, you can pull the metal stent and find the real bile duct tract and stent it, and will be okay, no harm done. But it's just, at the very least, it's extra procedure and certainly embarrassment to you if you place the wrong thing. So in conclusion, stenting has evolved significantly over the last, since 1979. And metal stent is pretty easy. They come in one shape, is straight, but plastic comes in all shapes. So they can be used in different ways. And so you have to know what to use. And then usage of lumen opposing stents are still evolving, but the fundamental requirement is that you have to be skilled and know when to apply them. Thank you very much.
Great, Simon, thank you. That was excellent, sage advice for all of us.